Ms. Schwalbe, vaccination rates are really variable, highly variable geographically across the world and in different social and cultural contexts. Can you talk about some of your recent work in New York and how they may relate to global rates of vaccination patterns, distribution, and what we can do to help improve them?
Great. Thank you so much. And thanks for this very impressive class of 73. I'm the class secretary for my class, and I must say that the acumen with which you've organized this is a lesson to us all. So it will certainly brought back to our class, and greetings to any 88ers on the call. So I work in a field which we call precision public health. And the idea is to use data from traditional and emerging sources to target interventions for populations by person, place, and time, with a focus exactly on reducing health disparities. Precision public health involves working with and for communities with a heavy focus on community engagement. And as the two previous colleagues have both said, from the first studies from Wuhan in early 2020, the data were crystal clear. We were never all at equal risk of severe outcomes from COVID-19. Those most at risk were the elderly and people with underlying health conditions, including diabetes, heart disease, obesity, hypertension. So underlying health conditions are highly correlated with what we call social determinants of health. The most important, at least from a statistical perspective of social determinants, are socioeconomic status and education. And these are often intersectional with other determinants. Race and ethnicity are also critical as they affect both access to and quality of care received. So as with other health issues, the very underlying conditions that make people vulnerable to severe COVID are driven by social determinants. And those with unmanaged chronic conditions, in other words, they didn't have or don't have access to care, are most vulnerable and were most vulnerable to severe COVID outcomes. And the result is what, if you read Richard Horton's Lancet article, what they call a syndemic, co-pandemic, underpinned by poverty and structural inequity. The unfortunate part is that social determinants have been completely underemphasized in our response. As Uche mentioned, in the US, Black and Brown Americans have the highest COVID death rates, and they also have the highest rates of obesity and diabetes. So in terms of the response, in addition to being prioritized for access to primary health care, they also should have been first in line for the vaccines. However, and I was Black and Hispanic New Yorkers make up about 30% of the population of our city and had the highest death rates. By the end of March, when vaccines were available, they made up only 18% of those vaccinated. And the statistics were pretty similarly grim for Black New Yorkers. So the criminal part of this, from my perspective, is that we didn't use the data that were available to target those most vulnerable, which led to avoidable deaths. In public health, the four components of access, when we talk about access to medicines, we talk about affordability, acceptability, availability, and accessibility. The media focused on acceptability and fixated on hesitancy. However, and I think again, Uche has mentioned this, accessibility was much more, if not the primary issue, certainly in the early days of the rollout. We have ample data here: morbidity, mortality by zip code, Medicaid, Medicare rosters, voter registration data. We know how many people live in each household, the age, the sex. We can sell them anything from the data we have available, and also data on race and ethnicity. But the vaccination strategy that was applied was really a one size fits all. The state focused on mass vaccination sites and asked the community to get to the vaccines instead of asking the vaccines to get to the community or bringing the vaccines to the community. From my work in District 1 in New York City, which covers a significant proportion of Lower Manhattan, we know the vulnerable could not get access to the early vaccine appointments. The mass sites were far from the community. I mean, I don't know how many people in this call who live in New York have actually even been to the Javits Center. They were hard to get to. There were language issues, lack of translation, internet-related barriers, and demand far exceeded supply. And as also Uche mentioned, before people in category 1A or B had the chance to find appointments, the eligibility expanded, putting them further down the list. And many of the deaths that occurred after the vaccines were theoretically available were thus really avoidable, including in our community. So if we take that experience, I'll just shift now to the global situation and COVAX, which I'm sure many of you have read about the news. Last spring, the COVAX initiative was launched. COVAX is a global collaboration designed to facilitate the development of and access to COVID vaccines for all countries. Through the COVAX facility, low-income countries can request doses at no cost through a scheme subsidized by donors. And middle and high-income countries can also purchase doses through this mechanism. Unfortunately, the mechanism has hit a number of roadblocks. First, there have been issues around affordability, and Ken spoke to some of that, with a lack of adequate financing to reserve the required doses. So a lot of countries sort of reserved doses up front before they were available, but you had to pay up front for that reservation, an options market essentially. Second, there have been problems around availability and supply constraints. So of the 1.8 billion doses required to vaccinate 20 to 30% of the populations of the poorest countries, so 1.8 billion doses required, only about 53 million doses have been delivered to date. And this, as Ken mentioned, has been further constrained by India. What probably most people don't know is the majority of vaccines for low-income countries are actually produced in India. So when India restricted export, that obviously affected COVAX. They were the biggest supplier to the COVAX facility. Third, there are reports that acceptability has been an issue, and some countries, because of hesitancy or lack of confidence, have not been able to distribute the doses they have received. But finally, and this is the critical point, is as we saw in New York, is the issue of accessibility. And while in some countries, weak health systems constrain delivery and few doses of those received have been distributed. So we do have countries that have received, DRC has received over 1 million doses and distributed less than 1% of those. For others that have exhausted their supply, so a bunch of countries got the supply and have finished them, there's actually no data on who the doses went to and whether they went to frontline health workers or those most at risk. And anecdotally, what we hear is that also in the poorest countries, the wealthiest have been first in line. So on the global scale, while the media focuses on affordability, availability, rightly intellectual property, dose sharing, the US hoarding doses, both of which are incredibly important, we also really need to double down on accessibility. Because as what we are seeing on the ground in low-income countries and middle-income countries is exactly what we saw here in District 1 and New York. Even where doses are available, those at the highest risk of severe COVID, particularly those who are structurally marginalized, are just not first in line in terms of access.